Welcome back to the Doctor is In television program. I'm Dr. David Morwood. Thank you very much for being here. As you know, I am a plastic surgeon, board certified here in beautiful Monterey, California. During this first segment, I'd like to talk about one area of plastic surgery that is perhaps growing more rapidly than any other field, and that is the minimally invasive treatments, non-invasive treatments, so-called lunchtime treatments that we offer in my office or in our medical spa and laser center, the Revitalescence Med Spa here in Monterey. Essentially, lunchtime treatments or non-invasive or minimally invasive treatments involve things such as mini peels, even mini lifts, Botox, injectables, fillers, etc. So what I'd like to do for a few minutes during this segment is talk about what this growing field of medical spa treatments is about, more about injectables, a little bit about Botox, a little bit about fillers, how and when I recommend mini lifts, mini peels, etc. So, as we begin, once again, it's important that we turn back to our concept of the facial beauty triangle. The triangle of facial rejuvenation and restoration. As you know, the triangle has three parts, and the triangle rests upon a foundation. The three corners of the triangle are, number one, the skin. We're talking about the texture of the skin, the very surface of the skin. Number two, we're talking about the volume of the face. As you know, you've heard me say multiple times now, as we mature, we tend to lose volume, we tend to lose fat in the face and in the back of the hands, and we put that fat and that volume on in the trunk. It's an unfunny practical joke. Now, some authors have described that as we lose the fat in the face, we do gain fat not only in the trunk, but we may gain some fat in the neck. I think that is somewhat debatable. There are certainly some people who seem to get a much heavier neck with time as we mature, and we'll talk about that as we go along. But certainly, everyone agrees that as we mature, we lose fat in the face and in the hands, and we gain that fat on in the trunk. Now, the third, as I said, the first part of the triangle is the skin. The second corner of the triangle is volume. The third part of the triangle is that soft tissue, position, structure, and amount. We certainly lose resilience of the skin with time. As the midface loses volume, that allows gravity to act on it. We get something called midface descent. The jowls get heavier, the nasolabial folds get more prominent, and we get a descent of the tissues as it follows gravity. Now, that triangle rests upon a foundation. That's the cranial facial skeleton. That's the foundation, the cheekbones, the chin. Sometimes we talk about the nose and the ears. We can even talk about sometimes the skull, the forehead, because certainly there's a change in volume and a slight shifting of the upper jaw, of the maxilla with time and as we mature. So, lunchtime treatments, minimally invasive treatments, or non-invasive treatments. Let's start with the skin. First of all, anybody who lives in California, I think, is a candidate for good skin care. I've equated this in the past. You've heard me talk about good skin care can be equated to good dental care. 2 or 3 times a year, you want to see your dental hygienist and get an evaluation, perhaps by your dentist and the dental hygienist. You might get x-rays, and you might get a good cleaning. However, that's not at all sufficient. What's important for you to do at home is your brushing and your flossing. You might be using a dental pick, a water pick, etc. But most of the work you do to take care of your dental hygiene, to take care of your teeth, be true to your teeth or else they will be false to you. Most of the work is done by you at home, and it's very similar to skincare. We can get you high quality medical grade skincare products to help you take care of your skin. You can get very efficient at the regimen. And so if you see your esthetician every 6 to 8 weeks or even a few times a year, and then you're doing good skincare at home, doing that skincare properly, you can really improve the health of your skin. Now, I think it's probably a good idea for me to run through briefly the very basic elements of high-quality skincare. First of all, avoid direct sun. We've spoken about how the UV rays of the sun can really play havoc and cause damage of the skin, especially the collagen layer. Now, next we go to properly cleansing the skin. Your esthetician, dermatologist, or plastic surgeon can teach you about that. Some people have oily patches, some people have dry patches, so it's very important for you to learn how to properly cleanse your skin according to your own skin type. Exfoliation. The very top layer of the skin is not living. That's the keratin layer. It's like nails and like hair. When that keratin layer gets too thick, the skin loses its sheen. It takes on a kind of a dull appearance. It loses its glow. So what we want to do is thin out that keratin layer to a more attractive thickness. We want the very top layer skin of the epidermis, very top cells of the epidermis to shed, thereby allowing new cells to come in. Now, we want to encourage regeneration. In the germinal matrix, where the new baby cells are formed down in that basal membrane, a basal cell layer, we want to encourage that factory to be turned on and make new baby cells that will come to the top. Now, please keep in mind that takes about at least 30 days, sometimes 45 days or more, before that new baby cell can get to the top layer. So you've heard me say, sometimes I hear Dr. Morwood, you know, I did skincare for 2 weeks and I don't notice any difference. You haven't even given your you haven't even given your skin a whole cycle's chance for those baby cells to get to the top. It takes 30 to 45 days at least for those baby cells to get to the top layer where they can be seen. So give yourself a chance, give yourself a cycle at least for those baby cells to come. And then if you keep it up for 6 cycles, you can actually have markedly improved appearance to your skin and better health. Now, we talked about the exfoliation, we talked about avoiding sun, we talked about encouraging regeneration. It's very important to properly moisturize your skin. As we thin out the keratin layer and as we exfoliate, your skin can really become dry and exposed to the elements, wind, and the sun, etc. Moisturizing is very important, especially around the eyes. Some people think they have fine lines and crepey skin. It's really that the skin is dried out. An esthetician can teach you about properly moisturizing your skin without clogging up your pores. Now, before I go on, it's important to talk about avoiding smoking. Everybody's familiar with antioxidants in superfoods like blueberries and acai berries, etc. That word antioxidants is pretty ubiquitous. Well, certainly cigarette smoke does the opposite. One puff of cigarette smoke contains thousands of oxidants. And what happens is it's like letting your microvasculature, the vessels that supply the skin, and organs like the heart and liver and kidneys to become kind of rusty and clogged. So if you do nothing else but avoid smoking, or even secondhand smoke, and avoid the sun, the rest is pretty straightforward. Properly cleansing and exfoliating and regenerating and moisturizing, those are essentials. But keep in mind, avoiding direct sun, avoid those direct UV rays, and no smoking or exposed to secondhand smoke. So those are the basics of doing skincare at home. The esthetician can do mini peels for you. They can do fruit acid peels. They can do very dilute TCA peels. They can do glycolic acid peels. They can do dermal stimulating treatments. They can improve the glow of your skin, improve vascularity of their skin. They can help you with a lymphatic massage, especially after a surgical procedure. So I'm a big believer in facials and seeing an esthetician that you connect with, getting a skin evaluation by your plastic surgeon, esthetician, dermatologist. I think that can go a long way. Now, if we look at our injectable category, let's talk about Botox. There's a lot of misconceptions about Botox. When all is said and done, Botox is a muscle relaxant. So let's think about the accordion. The muscles underneath the skin that allow you to make expression, those are called the mimetic muscular muscles of the face. They allow you to make expression, furrow your brow, knit your brows, raise your eyebrows, smile, etc. That's like an accordion. So the muscles go back and forth and contract. And what happens is the overlying skin, you don't see the muscles move, but you see the overlying skin move. And that's how we can get wrinkles and irides and furrows. Think of the accordion and think of taking a piece of paper where you fold it. If you fold a piece of paper 1,000 times, eventually, even when you stop folding the paper, there will be a permanent crease. And that's essentially a wrinkle or rided. Now, there are such things as passive or static lines and wrinkles, and there are such things as dynamic lines and dynamic wrinkles. So the difference is, if your skin is perfectly smooth when you're in repose, that's at rest. And then when you move or make an expression, then you see lines of expression. Those are called active or expressive lines. When your face is in repose and you're not even making expressions, you're not even contracting those muscles, and you still have lines, well, those are passive lines or etchings. And that is, again, as I said, even when you stop folding a piece of paper 1,000 times, after 1,000 times, there will be a crease. So that's a line or line of expression or rided or wrinkle. So we can treat those a little differently. Certainly, Botox is very effective around the eyes for the active lines of expression. In other words, if when you're in repose, you don't have any lines or wrinkles, Botox will prevent you from developing those lines. Now, what about the passive lines? What about when you're not even making expressions, when you have wrinkles or irides or grooves? Botox can certainly help soften those lines, because with time and more than one treatment, multiple treatments, the underlying muscles relax, sometimes spread out. The overlying skin does relax, and with skin care, we can help soften those lines because there's no muscular activity underneath to reinforce or restore those lines or those wrinkles. So we can help with that. Before I go on to talk about revolumization and fillers, how fillers can help with static lines, I want to talk about using Botox to do conservative, conservative non-surgical sculpting of the face. So, I said before that Botox is a muscle relaxant. There are certain places, for example, the eyebrows, where we know that there are 3 major depressors of the brows, and there's 1 major elevator of the eyebrows. So the 3 major depressors of the eyebrows, that's the orbicularis oculi, that's like a sphincteric muscle around the eyeball, around the globes, inside the eyelid, and there's the procerus and the corrugator muscles, and there's 1 major elevator of the forehead and eyebrows, and that's the frontalis muscle. So, using Botox, we can selectively get the depressors to relax, we can allow the elevators to take over, and we can do some conservative shaping of the brow, especially when we want to get a little conservative elevation of the lateral brow. That can be very effective. It's not as dramatic as a surgical lateral brow elevation or surgical lift, but of course with Botox there's no incisions and there's hardly any downtime. It's a lunchtime treatment. There may be swelling and bruising for a couple of days or a few days, but it's effective. Now it is temporary. Botox, the effect of botulinum toxin, Botox cosmetic lasts, well, it's about, I tell my patients 5-ish months. Some people it lasts 6 to 7 months. Other people seem to metabolize it quicker, 3 to 4 months. Certainly what I can tell you is, with repeated treatments, those muscles never return to their original strength. They never regain their original dynamic quality. And so my patients tend to need fewer units, and they tend to need treatments more often. And they can get an effect. I think it's great around the eyes. I'm very, very conservative. I'm very judicious around the mouth because I don't want to change people's smiles. One area where it does work, around the chin, I can soften excessive mentalis constriction, the sort of wrinkles that some people get in their chin. We can turn up the corners of the mouth. We can get a muscle called the depressor anguli oris and the depressor oris to relax. Depressor anguli oris, DAO, as I mentioned, we can get those muscles to relax. And that way, the elevators can take over, the zygomaticus and the elevators, and then we can help conservatively turn the corners of the mouth up. It works very well actually for platysmal bands in the neck. When the platysma, the muscle that's deep to the skin and the fat, has some bands. Some people call that the turkey neck or wattle neck. Now, it's true that Botox can be effective there. The downside is it takes a lot of units. I only give in my office probably a maximum of 50 units in a day. So if I want to treat the entire platysma muscle on one side, I can do that with 50 units. I can soften platysmal bands with 10 or 20 units. But if we totally want to treat it, that's about 50 units, and I only do one side per day. And it's temporary. It's not as powerful, certainly not as long-lasting as a surgical platysmoplasty, but again, there's minimal downtime, no downtime. It's a lunchtime treatment. So let's go on to the other part of the other commonly used injectable, and that's fillers. We could talk about fillers for a whole hour. Of course, you've heard me talk about volume restoration in the face. There are two big categories of volumizing the face, or revolumizing. When we lift and fill, or only fill, there's your own fat, and there are artificial fillers. Most of them are made of hyaluronic acids. A few are calcium-based. There's one called, less commonly used, PLMA. I don't use that very often. It's sold as a way to have your body replace that chemical with its own collagen. I tend to use hyaluronic acids, hyaluronic-based fillers, Belotero, Voluma, Juvederm, Restylane, etc. I think they're very effective. They can be reversed with a hyaluronidase if needed. So that's, besides fat grafting, we can use fillers to help revolumize. Now, some of my favorite uses of fillers are to give people higher cheekbones, or to restore their volume of the cheekbones, to bring the chin forward, sometimes make the mandibular angles, the corners of the jaw back here. It's kind of in vogue now. It's kind of trendy, even in women, to have a strong jaw, especially the chin and the posterior mandibular angles. There's some very well-known celebrities, men and women, that have quite striking and well-sculpted jaws. And a lot of that's filler or fat. We want to show off the posterior, the mandibular angles. And that'll actually give people a little micro lift. The piriform sinus areas, piriform apertures here, that can be revolumized. Of course, that's one of the areas where that was fat grafting was first done. It can be very effective to fat graft to the piriform areas. Bringing the cheekbones forward gives people a micro lift, can do micro softening of the nasolabial folds. The temples oftentimes can be filled with fillers. Now, the tear troughs, or that eyelid-cheek junction, that's a very key part of the attractive face. When we see a mannequin or we see a model in a glamour magazine, typically it's a very smooth eyelid-cheek junction. And in a magazine, most of those models, men and women, have airbrushed eyelid-cheek junctions. But we can soften that groove with fillers. I think that's a very effective treatment. You heard me talk about earlier that some static lines, for example, if even when your face is in repose or resting, Botox can help soften that line. But if you want to go one step further, oftentimes we can use a filler to kind of fill in that area. It's sort of like taking a piece of paper that has a crease and really almost ironing it, really turning it over and rubbing that fold in the paper to get it as smooth as possible. So we talked about skincare, we talked about injectables, including filler. Before I go on to talk about mini lifts, keep in mind that there are many different kinds of fillers. We categorize them according to what they're made of, the substance. Typically, I use hyaluronic acids. There's also a calcium-based filler called a Radiesse. There's a Sculptra that is PLMA-based. It's sold as a semi-permanent filler. We inject it, and the company says that the material is resorbed and replaced by a body's own collagen. I'd say that's a less commonly used filler. Hyaluronic acid fillers can be categorized further by their thickness or G value. Something like a Belotero that I use under thin skin in the tear troughs, or more superficially, say for the lip. lines, that has a very low G value. It tends to be almost like an oil. It's very thin. It can go superficial. And it tends to minimize the Tyndall effect. The Tyndall effect is when a hyaluronic acid is injected and some of the translucency or opacity of the dermis can be seen as with a kind of bluish hint or bluish tint. That's the Tyndall effect. Belotero tends to minimize that. It has a very low G value. Something like a Voluma is much heavier. It lasts a long time. The manufacturer says 1 to 2 years. That goes deep. I don't put that superficial. Has a very high G value. So there's all kinds of fillers. And of course, what we do in the medical spa and in my office, we take a custom designed approach. Now, very briefly, I said that the triangle of beauty, triangle of facial rejuvenation, has 3 parts. The skin, we've talked about skin care and getting mini peels and facials from the esthetician, doing your skin care at home. We talked about revolumizing. We talked about Botox. Now, what about soft tissue position and amount and resilience? A mini treatment, certainly our lunchtime treatment, does not include surgery. However, there are various mini lifts that we can do right in the office. I do mini lifts. I do short scar cheek elevations. Sometimes we do short scar neck lifts. So we can even do a submental platysmoplasty. Eyelid surgery we can do in the office. We can do a lateral brow elevation. Certainly very limited facelifts we can do in the office. We can do limited body contouring in the office, but today's discussion really is about the face. So I tell my patients that it's important after a mini lift, short scar lift, submental lift, liposuction of the neck, etc. You've got to rest and take it easy at home for 3 days and 3 nights. However, on day 4, we have plenty of people who will go back and sit at their desk, do paperwork, take phone calls, etc. On day 11, then slowly get back to your life. So we do consider that minimally invasive. It's certainly not non-invasive. Incisions have to be made, but we can get a lot out of well-planned incisions and mini lifts for the right patient, combined especially, say, with micro-fat grafting. We can do a little bit of micro-fat grafting in the office. We do a little conservative liposuction, spin the fat down, decant it, or centrifuge it, keep it sterile, sometimes surgically cleanse it, and that can be re-injected with kind of a needle or cannula, micro-cannula, to bring the cheekbones forward, to bring the chin forward, temples, soften the nasolabial folds, or pre-gel sulcus to accent the posterior mandibular angles. So those are things we can do in the office at lunchtime. Again, for skin care, there's really no downtime. For injectables like Botox and fillers, there might be bruising and swelling for a couple of days. You can hide that with makeup. The mini lifts, yes, there are incisions and there are scars, but you rest at home for 3 days and 3 nights. On day 4, more activity, but don't get your blood pressure up high. On day 11, slowly get back to your life. Foundational changes, the triangle of beauty rests upon the foundation. We can do some conservative sculpting, like I said. We can give people higher cheekbones, bring the chin forward, but certainly if we're going to do surgical reshaping of the craniofacial skeleton, if we're going to bring the chin forward or put in a chin implant or dramatically affect the craniofacial foundation, that's an operation. I don't consider that minimally invasive or even certainly not non-invasive. That's invasive surgery. But the more invasive a procedure, typically the more powerful, the greater the effect, and the greater the duration of lasting. That's an introduction to lunchtime treatments, minimally invasive, non-invasive plastic surgery procedures. If you'd like to visit our med spa, if you have any additional questions about the med spa or minimally invasive treatments or anything to do to improve your appearance, I hope you will call my office here in Monterey, 831-646-8661, or go to my website, drmorwood.com. That's DRMORWOOD. Thank you very much for joining us. This is the Doctor Is In television program. I'm Dr. David Morwood. We're going to take a very brief pause for a very good cause.
It's scary making the decision to have reconstructive surgery, but it's so worth what you get out of it.
I'm stress-free. I know I'm not going to get breast cancer.
Everything is back to normal, and it really did not take long to bounce back.
I have a sense of hope for other women that this surgery can help them to live normal lives.
This year, more than 200,000 women in this country will be diagnosed with breast cancer. For many of them, a mastectomy or removal of the affected breast will be recommended as part of the cancer treatment.
The idea of losing a breast for some women can be almost as difficult as being diagnosed with breast cancer. Modern breast reconstruction can help. The purpose of this presentation is to provide women with valuable information about the major issues in breast reconstruction.
We'll have an opportunity to speak with women who chose different methods of reconstruction. We'll talk to experts in the field of breast cancer, and we'll let you know your options for breast reconstruction.
I embraced the mastectomy and reconstruction procedure, and because of that, I had a terrific outcome, and it's changed my life in a positive way.
For the thousands of women who will be diagnosed with breast cancer this year, we understand this is most likely a troubling and frustrating time. We hope this presentation's been valuable to you and will help you make some very difficult decisions that you're facing.
Welcome back to the Doctor Is In television program. I'm Dr. David Morwood. I'm a board-certified plastic surgeon here in beautiful Monterey, California. Thanks very much for tuning in. What I'd like to talk about in this next segment is the difference between the so-called full facelift or complete facelift and the so-called mini lift or short scar lift or light lift or S-lift, etc. It has many different names. Well, what I'd like to get clear with you is that nobody really knows what a complete facelift is. Nobody really knows what a full facelift is. Over the years, different people have used different techniques and called these procedures different things. Some people tell me that the complete facelift or a full facelift includes a nose job, a rhinoplasty. They say it includes the eyelids. That's a blepharoplasty. It includes the neck and the cheeks, or it includes a peel, or it includes fat grafting. Nobody really knows. What I can tell you is that in my practice and in my office, I'm an advocate of a custom designed approach. What we need to do is look at you, and we need to look at a mirror, we need to look at your photos, we can go through your Vectra computer imager, and I can do some conservative surgical sculpting. But the most important issue is, what do you want to change? What is it that you want to affect? And I think that looking in a mirror can be very effective. Looking at your photographs with me can be very effective. Bringing in photographs from years prior can be a very great communication tool. And of course, the Vectra computer imager can be a very valuable tool of communication. The Vectra computer imager is a great piece of technology. Costs us about $40,000. It's been well worth it. You sit or stand in front of this. It's like a computer. It has 6 cameras, six lenses. It takes your image, just like having your picture taken. It feeds that data into the computer. The computer will process that data, and we can sit at the computer terminal at the display, and we can turn you in different directions in your 3-dimensional model, and we can do some conservative shaping, conservative sculpting, etc. And most importantly, you can look at the display with me and you can point things out. Nobody ever gets to see themselves from the profile view or from the side. Nobody gets to see themselves from underneath, or the worm's eye view, or the bird's eye view, or a 3/4 view. So we can do that, and we can manipulate it, and you can tell me what it is that you want to change. We can also do that for the breasts or for the body when we talk about breast lifts, breast augmentation, body contouring. It can be very helpful, great tool of communication. So, what about facial rejuvenation and facelifting? Well, what I can tell you is, when we talk about, if someone comes in and they say, Dr. Morwood, I really want a complete facelift, or I want a full facelift, I think what's really the important issue, the important concept is that he and I, or she and I, sit down and get specific about what he or she wants to change. What is it that you see? What do you want to change? Let's look at your pictures together. Now, certainly, when somebody says to me, Dr. Morwood, what do you think? What do you think I should do? I am happy to offer my opinion. I'm happy to discuss what can be done that's effective and safe. However, beauty is in the eye, and it's your face. We all age differently. I find it really fascinating. Sometimes people come in and say, I think I'm starting to look like my mother, or I'm noticing I'm starting to have my father's eyelids, and they want to change that for various reasons. So it's really important that we sit down and talk to you. But certainly I can tell you about mini lifting, short scar approaches. For example, if we're going to talk about the classical approach to a traditional facelift, that starts with incisions up in the temple. It comes down just behind the so-called sideburns, a temporal tuft of hair, sometimes in front, under and around, to the crease in front of the ear. A newer approach is the tragal incision. That's just at the junction of the ear cartilage and the cheek. It's not really inside the ear canal, but it's at that junction. And then under and around the earlobe to the crease in the back of the ear, across this bone here called the mastoid, and then into the hairline here of the mastoid, this hairline. And oftentimes that's accompanied by an incision in the crease just underneath the chin, a submental incision. Through those incisions, we can open up and gain access. We can affect the fat compartments. We can redrape muscles. We can affect the SMAS, the SMAS, superficial musculo-aponeurotic system. That's the fascia that's underneath the skin and the fat in the face. And oftentimes we'll imbricate that or transpose it, elevate it, and that allows us to have a much longer lasting lift. So those procedures tend to come with a so-called full facelift or complete lift. Now, what about a mini lift? I like doing mini lifts, oftentimes in the office. They are much more simple, straightforward. They are for people who do not want a dramatic change. We can still get an effect that lasts for 7 to 15 years. I can still affect the SMAS layer to a certain degree. So where are the incisions for that? In general, again, it's custom designed approach. Let's say someone comes in and they only want their neck redraped or tightened. Then oftentimes I will make incisions only in the back of the ear and across the mastoid and up into the hairline here. Sometimes I will come under and around the earlobe, just to the crease here. This is the tragus, that little piece of cartilage that stands up, and almost like an S-shaped. And with that way, I can get a fairly effective lateral platysmoplasty, and I can remove skin, tighten skin, improve the resilience and the tone of the skin to give someone a much crisper, firmer, well-defined chin and jaw and neckline. That may be accompanied by a submental incision in the crease right underneath the chin, where most Americans have a scar anyway. You perhaps have heard me say the majority of Americans I meet already have a scar there. They fell from their bike, or their little brother pushed them off the stairs, or they fell on a curb, etc. So they have a scar under their chin anyway, a short scar there. I can take out fat, I can mold and shape and tailor. Sometimes I can tighten the platysma muscle in a mini approach. Now, if someone wants to more affect or concentrate on their cheek and jowls, it's probably going to be something like an S-lift or a light lift. That starts just around the temporal tuft of the hair, around the so-called sideburns, up to the root, or the root of the helix to the top of the ear, down into that crease, or just at the edge of that cartilage, the tragus, under and around the earlobe, and then for a short distance into the back, that crease in the back of the ear. There's something called an MACS lift, a max lift. And what that is a short scar incision where we can then imbricate the tissues, imbricate the SMAS, remove some skin, and it's an approach that's a lot less invasive than the so-called complete facelift. Now, at the same time, we can do fat grafting, for example. Briefly, fat grafting is when we do conservative liposuction, say of the tummy or the flanks. Most of us have some fat in the trunk that we're happy to give up. We can spin it down, we can centrifuge it, we can decant it, and that purified fat, we can surgically cleanse it. That purified fat can be re-injected with it's a needle, it's a cannula. It's kind of a large needle, and so we can inject it into on the top of the cheekbones, to the chin, various areas that need to be revolumized. We overcorrect doing that. The incisions are very small. When I say overcorrect, we know about 67% of the volume will persist. So we overcorrect, we make people bigger and fuller than they want to be eventually. The advantage is it's your tissue. If you ever gain weight, well, those areas will get bigger, just like a natural face. When you lose weight, your face and those fat compartments get smaller. It's your own tissue. It's living, breathing tissue. It takes root. It can grow, atrophy, replicate, etc. It's a living tissue. It's like a living replacement. It's a natural replacement for fillers. You don't have to have Belotero or volume, etc. Most of us have enough fat to give up, so we don't have to pay the manufacturer for the filler. It's certainly a surgical procedure, but it doesn't have to be elaborate, doesn't have to be complicated. Now, just to be complete, you probably know that there's a so-called natural breast augmentation where we use a woman's own fat. There's a so-called Brazilian butt lift where we do fat grafting to increase the size or the roundness or the projection, change the shape of the buttocks. That tends to be much more higher volume. That's almost never done in the office, I would say. On occasion, I'll do a small, well, moderate amount of natural breast augmentation to be done in the office. But typically, when we do fat grafting in the office, it's for conservative augmentation, or I should say relatively low volume improvement for the face. And it doesn't take a lot anyway. 10 or 20 cc's of decanted fat or centrifuge fat to the cheekbones can go a long way. It's interesting to me that oftentimes women will request that their earlobes will be revolumized because they start to see one or two big creases in the earlobe that's unattractive and they want to wear their pretty earrings. So again, fat grafting can be done in the office. It tends to be a minimally invasive procedure. So if someone says to me, for example, well, they just want their upper eyelids done and we want to elevate the lateral brow, I think that's a relatively straightforward procedure that can be done in the office. Certainly I do a lot of that in the office. Sometimes lower lids. Lower lids tend to be a little more complicated, but that's what we call a short procedure, kind of a mini procedure that can easily be done in the office. Along with a mini lift of the face, a mini lift of the neck, fat grafting, etc. Now, there are some people who come to me and only need or want a mini lift, whether it's a mini neck lift, mini cheek lift, mini face lift, cheek and jowl lift, etc. And they don't really want to be awake in the office, or they don't want to be sedated. They want to totally take a nap. Now, that's okay with me. I'm not judgmental. We do plenty of those procedures on an outpatient basis, either at the surgery center or at the outpatient surgery center at the hospital. What is it that we do offer in the office? Typically, when someone will have a procedure in the office, they need to be healthy, of course, no uncontrolled medical problems, no uncontrolled diabetes, certainly no uncontrolled high blood pressure, no history of a cardiac problem such as ischemia, no history of a cardiac bypass or myocardial infarction. Their lungs need to be in good shape, etc. Shorter procedures are good for the office. What happens is they come in and we check their vital signs. We can give them oral medications, pills. We don't start an IV in the office. So we can give you an oral relaxant, we can give you Benadryl, Tylenol, sometimes a narcotic by mouth, such as Norco. We can give you antibiotics by mouth. We let you relax and get very mellow, and people do get mellow. And we monitor you. We have a pulse oximeter. We check your pulse. We check your blood pressure, etc., etc., etc. We're monitoring you. Then we can numb up the skin, and I can go slowly, and I can buffer it, buffer the numbing medicine. But let me back up for a moment. When I numb up the skin, it stings because it's a needle. But I can go slowly. So then we let that soak in and we take our time. Then we numb up the deeper tissues, usually through very mini axis incisions with a big needle or a very small mini incision. I can put in something called Hunsted's formula. It's a very dilute solution of local lidocaine and Ringer's lactate with some epinephrine to constrict the vessels. That makes the deeper tissues numb. So then we let that soak in. Now, there's one additional step we can take in the office. It's a patient-administered device, the Pronox machine. It gives nitrous oxide. It's a mix of oxygen and nitrous oxide. Many of you are familiar because you've been to the dentist, and they administer or use or employ what they call sedation dentistry. You can take that by mask in the dentist's office. What we have is kind of a oral tube, and you administer yourself that nitrous oxide, and so it really is kind of a dissociative anesthetic. Nothing bothers you. You might be aware that you're getting numbed up, but it doesn't really bother you. After about 5 or 6 puffs of the nitrous oxide, nothing seems to bother you, and it is rapidly blown off. You get over it very quickly. It has a good safety profile, and it can be effective for people who are anxious about having a needle or anxious about getting numbed up. It's used for children and adults in many emergency rooms throughout the country. It's even being used now for women in labor. It seems to be very safe. There's no issues about crossing the placenta, etc. So that's the Pronox, nitrous oxide. We can use that combination. And so in the office, we can do quite a bit. So I hope that gives you some idea of the difference between a mini lift and a total facelift or complete facelift. I advocate a custom designed approach. We need to sit with you, look at your pictures from years ago, look in a mirror together with you, look at your vector image, and then once we get clear on what it is that you want, what it is that you want to change, because that is key, that's the most important element, what you want to change, then we can custom design an approach for you. We talk about time off, we can talk about safety, we can talk about duration of duration of the action of that, we can talk about the cost. We want everything to be out in the open, the length of the incisions, scars, etc. Custom design an approach for you to together develop something that fits for you, that's effective, because we want 99% plus delighted people. If you have any additional questions about mini lifts or short scar lifts or complete facelifts or neck lifts, I hope you'll go to my website, drmorwood.com, that's DRMORWOOD, or call my office here in beautiful Monterey, California, 831-646-8661. Keep the spot you got. We're going to come right back after a very brief pause for a very good cause. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. Here in California, we all love the outdoors. Golf, tennis, going to the beach. However, the sun can play havoc with the delicate skin on the back of the hands and neck. Call or click today to learn the newest methods for restoration and beautification of the hands, neck, and other areas affected by the sun. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. One of the common goals I share with my patients is that they look natural after their facial rejuvenation.
Dr. Morwood made me feel really comfortable. His staff is phenomenal. Going into his office is always a great experience.
Call or click today to learn how our combined approach of art and science can enhance your natural beauty. Hello, I'm Dr. David Morwood. I have over 25 years experience in plastic surgery. A smooth, firm neckline is a universal sign of beauty in both women and men.
Dr. Morwood not only helped me regain my confidence, he helped me achieve the best version of me.
Call or click today to learn how the natural neck lift can rejuvenate your beautiful neck and jawline. Welcome back to the Doctor is in television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon right here in beautiful Monterey, California. Monterey, Pebble Beach, Carmel by the Sea, Carmel Valley, and Pacific Grove. During this next segment, I am so honored and pleased and delighted to welcome back to the studio Dr. Dan Luba, gastroenterologist. Dr. Luba, you just about flew into the studio. Thanks very much for being here. Great to have you.
Thank you.
Dr. Luba, you're a board-certified gastroenterologist. You've been on the program again. You're a terrific teacher. You're one of the area's foremost experts in cancer of the GI tract. I'd like to teach our audience today about something that I think is actually very common, ill understood, a lot of misconceptions about it, and so I want to learn a lot about it, and in the meantime we're going to teach our audience, and that's inflammatory bowel disease, or IBD. Isn't that correct?
Yes.
So Dr. Luba, let's start by outlining what we mean by IBD, or inflammatory bowel disease.
So inflammatory bowel disease basically consists of two types. One is Crohn's disease, the other is ulcerative colitis. And those are the two types of inflammatory bowel diseases.
Okay, so there's Crohn's disease and there's ulcerative colitis, and they together make up this group. Well, it's two components of inflammatory bowel disease. So I'd like to know, how are they similar? How are they different? How does somebody get an inflammatory bowel disease? And what's the natural history of it? And can we treat them? And et cetera. And who gets it? Who gets inflammatory bowel disease?
Well, anybody can get it. Usually people will have some sort of a genetic predisposition, and then there's some environmental factor that seems to tip them off. And to understand that a little bit better, what I usually like to think about is that the GI tract is in a chronic state of very, very tightly controlled, tightly regulated inflammation. So there are actually more lymphocytes in the GI tract than there are in all the lymph nodes throughout the body. And the reason for that is because we're constantly introducing things into our body when we eat. And some of those things are good, and some of those things are bad. And so these cells are floating around, and basically they're looking at things and saying, is this a good thing for us to take into our body? And if it is, then they let it go. Or sometimes they say this is bad, and they then kill it. So normally it's very tightly regulated, and we don't have any problems with that. But occasionally that very tight control or regulation gets too high, and so these lymphocytes start attacking the body itself, the GI tract itself. And it depends on where it attacks the GI tract as to whether or not we say it's ulcerative colitis or Crohn's disease. So ulcerative colitis is limited to the colon, and it's a superficial inflammation. Doesn't mean it's not significant, but it means it's a superficial inflammation. Crohn's disease can occur anywhere in the GI tract, from the esophagus all the way down to the colon, and it can go through the entire the wall of the GI tract. So it's not just a superficial layer of the lining of the GI tract, but the whole wall of the GI tract can be involved. And that leads to the differences in presentation.
Okay, so Dr. Luba, I have a question for you. On this program before, we've learned or talked about how itis, those four letters, I-T-I-S, in Greek means inflammation. Mm-hmm. So in the GI tract, I'm very fascinated. You said that the GI tract is constantly under a very well-controlled, regulated inflammatory process. We can have esophagitis. We can have pharyngitis. We can have gastritis. I guess we can have duodenitis. That must be rare. We can have ileitis. We can have colitis. So there's all kinds of different ways that the GI tract gets inflamed. Isn't that correct? Mm-hmm. So when we say that Crohn's disease can affect almost anywhere in the GI tract, but it's more full thickness, it's a more invasive inflammation, is that correct? Mm-hmm. So do you consider Crohn's disease a more severe kind of inflammation as opposed to ulcerative colitis?
Well, both of them can cause severe symptoms, but they can cause different symptoms. So ulcerative colitis usually presents with diarrhea, and sometimes it can be bloody. Crohn's disease can present the same way, but because it goes through the entire wall, imagine if there's an inflamed wall here, abutting another wall of another, let's say, loop of bowel. If this is inflamed all the way through, then what can happen is it can start to affect this piece, this loop of bowel, and you can actually get fistulas or communications between the two. You don't see that in ulcerative colitis. It can also, because the entire wall is involved, it can also get strictures or narrowing, where you don't see that in ulcerative colitis. And you can get blockages. If you have a bad enough narrowing, it can actually obstruct. So again, you don't see that stuff in ulcerative colitis. And the small bowel is involved with Crohn's disease, not infrequently. It doesn't have to be, but it can be. And you don't see that with ulcerative colitis. So ulcerative colitis, usually bloody diarrhea, but that can be really severe, very debilitating. Sometimes people have, it can be so bad and that sometimes people actually have to have their colons removed. We don't do that very much anymore, but it can happen. It's much more frequent to see operations in Crohn's disease because of blockages and fistulas, etc.
Okay, so the treatment regimens, can Crohn's disease be treated and those complications be prevented? Can ulcerative colitis be treated and complications be prevented?
Yeah, so, and we've developed a whole host of new treatments that are extremely effective now. So before, when I said it's a case of uncontrolled inflammation, meaning that the inflammatory cells or all the inflammatory cells are just at a very heightened, there's too much inflammation going on, and what we need to do is tamp down that inflammatory process. It used to be that we only had a couple of drugs, and the most potent one were steroids. And if you take steroids, it's basically a shotgun that just tamps down the entire immune system. Now we're getting a lot better at it, being able to just target a specific inflammatory mediator and tamp down that, and that can be much more effective with less side effects. So we're a lot more, we have a lot better treatment regimens now for both ulcerative colitis and Crohn's disease, and can actually change the natural history of them.
Okay, so again, so the natural history, untreated severe Crohn's disease, I am interpreting you, can lead to fistulas and big problems, it sounds like. Fistula is an abnormal connection within the body, or even draining to the outside. Ulcerative colitis can be debilitating, bloody diarrhea, but it sounds like with modern and proper treatment and diagnosis, they can both be treated and controlled. Isn't that correct?
That's correct.
Okay. So, Dr. Luba, we've discussed before how chronic inflammation almost anywhere in the body, in the lung, chronic lung irritation from smoking, chronic irritation of the skin from UV rays, chronic esophagitis, chronic colitis, that those chronic inflammatory processes can sometimes lead to degenerative cells, malignant degeneration. Isn't that correct?
Yes.
So in the GI tract, chronic inflammation of the esophagus, chronic inflammation of the stomach, gastritis, doesn't that lead you to want to intervene a little more aggressively if someone has a severe inflammation?
Well, yeah, and we see that, you know, when there's chronic inflammation in the esophagus, usually from acid coming back up, sometimes that can turn into something called Barrett's, where the lining of the esophagus starts to change and look more like the lining of the small intestine. And that can be a precancerous change. So what we do is we try to decrease the amount of acid exposure by giving medications to decrease the amount of acid in the stomach. In the same way, if we decrease the inflammation in the colon, we can actually reduce the risk of developing colon cancer. So people with ulcerative colitis, the longer the segment of colon that's involved, the higher the risk of cancer. So sometimes you can get ulcerative colitis just confined to the rectum, to the very end of the colon. Sometimes it can be part of the colon, and sometimes it can be the whole colon. The more involvement there is, the higher the risk of getting cancer. And we usually, after a certain number of years, we start to screen those people to make sure that they don't develop any malignant changes or precancerous changes so that we can prevent them from getting cancer.
Okay, so Dr. Luba, that's a perfect segue to my next question for you, and that's screening. I would like to take we do have a few minutes. I would like to take a minute to review the recommended screening for when we start recommending colonoscopy. And is upper upper endoscopy ever recommended as a screening tool or screening regimen? And then, how do these people present with inflammatory bowel disease and then get worked up? So I know I just asked you a lot of questions. So let's review the normal recommended screening schedule for colonoscopy. And my follow-up question is upper endoscopy, GI endoscopy, is that ever recommended as a routine screening?
So for colon cancer is the second leading cause of cancer death in the United States. So there is screening for that, and the screening for that is to do a colonoscopy. And the recommendation at this point is to start screening in average risk people at age 50 and to do it every 10 years. Now, there are other techniques that you can do besides colonoscopy. So you can check and see if there's blood in the stool. You can do other tests like a Cologuard test, looking for abnormal DNA in the stool. But ultimately, all of the tests are trying to find the highest risk people to get them to go undergo a colonoscopy, because the precursor of cancer are polyps. Those are little abnormal growths. And if we find a polyp during a colonoscopy, we can remove it. So it's not even really competing strategies. It's whether or not you want to take the entire population and have them get colonoscopies to find a polyp and remove it, or whether you want to find people who have maybe blood in their stool or some abnormal DNA and then have them do a colonoscopy to look for the polyp. But it's starting at age 50 for a colonoscopy every 10 years.
Okay, so Dr. Luba, is the upper GI inspection endoscopy, is that ever a routine screening tool?
Not for the general population. Now, if people have chronic heartburn and they get it frequently, especially if they're white males and they're over the age of 60 and they're overweight, or if they smoke, then yes, we usually do an upper endoscopy looking for Barrett's. If people have, refractory symptoms, in other words, they don't go away, we'll take a look. People of Asian descent, especially if there's a family history, they have a higher risk of stomach cancer, so we'll do it on them. And then if there are alarm symptoms, obviously, if somebody has weight loss or they have trouble swallowing, then we're going to look. But if somebody is healthy and they don't have any symptoms, then no, we don't do an upper endoscopy.
Okay, so back to our original topic of inflammatory bowel disease. Usually those people will present to their family doctor or the gastroenterologist with symptoms, isn't that right?
Yes.
So that's not discovered in screening.
Very, very rarely.
Okay, so they present with the symptoms, that's
right.
Bloody diarrhea or abdominal pain or even a fistula, etc. Mm-hmm. And then they get worked up and diagnosed, and then you can start the treatment regimen. So, Dr. Luba, we only have a couple more minutes. So who gets inflammatory bowel disease? Who gets Crohn's disease? Who gets ulcerative colitis? Is it certain ethnicities, certain segments of the population? Everybody in the world can get it?
We see it everywhere, and there is a genetic predisposition, but it's not real strong, and so it can be seen in pretty much everybody, whether it's men or women. There's different age groups that it starts at, but we can see it at any time. And it's not that uncommon. Data show that about maybe 1 in every 500 people will have ulcerative colitis, about 1 in 500 people will have Crohn's. So we see it not uncommon.
Dr. Dan Luba, board-certified gastroenterologist. He's a genius, great teacher. He's one of the foremost experts in this area on colon cancer. He also has an upcoming fundraiser to raise awareness about DNA and how that affects your incidence of colon cancer, etc. Dr. Luba, thanks very much for coming on the program. Dr. Dan Luba, once again, I'm Dr. David Morwood. I am a board-certified plastic surgeon here in beautiful Monterey, California. This is the Doctor is in Television program. I hope you'll tune in another time. Thanks very much for being here.